so I'm going to teach you a few practical examples of how the pupil can interact with your decision of the IOL choice. So quality without compromise. So I wanted to give a few practical examples of how to use this lens in clinical practice to get the very best results. Okay, so targeting for success. So we have a major problem with our lens choice these days, and we're always balancing quality of vision and quantity of vision. Of course, we want our patients and we want to prioritize the quality of vision, and we don't want to compromise quality just to get range or more quantity. But in an ideal world, we don't have the both. So I wanted to just share a couple examples to put this into your mind as far as how this works in clinical practice. So this is a patient of mine I recently did cataract surgery on. He's a monocular patient, essentially, 68-year-old man with a history of blurry vision in his right eye. He had fungal keratitis in his left eye and essentially best corrected his 2400. So this is a big deal for him. He's undergoing cataract surgery in his only eye, and we want to make the best choice. And so certainly I'm not thinking of a multifocal, or something with very complex optics for him, although he has a super healthy eye. Pretty dense cataract, 3+ NS, and he has a clear PK in the left eye with some cupping there as well. So I warned him, we're going to use a monofocal lens, but I'm going to use one of these more advanced monofocal lenses. And so we decided on the RayOne EMV. And post-op day one, I was really happy to see him. He was doing great at distance, 20/20, -2, and I did warn him he needs some reading glasses after this. But he was reading up close, J2. He's like, I don't need reading glasses. I read my paper this morning, no problem. And so I'm thinking, gosh, this is really impressive outcome with this lens. What just happened for this patient? So Carolini did a wonderful job of kind of explaining a little bit about what was going on with this patient. But as she mentioned, we have this aspheric anterior surface, we have the positive spherical aberration, which is giving us a bit more range of vision, and then we had the blended edge. And so, we've really managed to decrease dysphotopsias, taking the least risk as far as visual compromise, but again, adding a little bit more range to the patient. So how spherical aberration works. So inducing a little positive spherical aberration, you can see her shifted the curve a little bit toward the near end here. So this is really ideal in giving these patients just a little more range of vision in that near direction. And so here we can see, how we've extended the range just a little bit there. By adding a little positive spherical aberration, we can gain up to an extra diopter and a half in many patients. And I'll show you how to achieve that with targeting, which is really key here. And so again, we've mentioned we're broadening the defocus curve here, and this is really important to notice. You can see a little notch on the myopic side, but a broadened curve, as we go onto the near end of the defocus curve. And this is well illustrated here as compared to a standard monofocal lens illustrated in blue, which has higher MTF, but here we can see the comparison as well. Especially with a small pupil, the MTF difference is almost negligible. With a larger pupil, you get a slight decrease in MTF, but you're broadening that curve to give them more range as well without introducing dysphotopsias. So how do we target these patients to really achieve the best of both worlds? Maintaining the highest quality of vision by giving them range of vision as well. So we can introduce various forms of blended vision, and essentially mini monovision, and then finally up to full monovision. For full monovision with a lens like this, we're talking about a 1.5 offset, as opposed to more like a 2.5 with a standard monofocal lens. And you can see here, as we move from the left side to the right side, as we increase that little bit of offset there from 0.5 up to 1.5, we're separating the curves, and this is targeting the dominant eye for distance and the non-dominant eye with a little bit of mini monovision. But even with, on the left-hand example, with just 0.5 offset, you're getting up to 1.5 diopters of extended range there. And I'll show you that in the table in just a second. So this illustrates it perfectly. So you can see, this table is divided into three essentially columns here. So you can see you're targeting emetropia, you're even getting a little extra 1.5 diopters there. But as you move down, you're offset with the non-dominant eye from 0 at the top down to 0.25, 0.5, and all the way down to 1.5. At a minus 1.5 diopter offset, you're getting about 3 diopters of extended range. And so this is relative to a standard monofocal lens. So you're really getting a lot more. Even if you target just a minus 0.5, you're getting about 2 diopters of extra range of vision for these patients without introducing dysphotopsias, as you would see with more complex diffractive optics. Okay. And this kind of illustrates that same idea, but really applies it to real life. You know, how these patients, as you can see, emetropia, the mini monovision, and bumping it on up all the way up to minus 1.5 diopters, which would give you full range of vision. So I just wanted to show this example. He's a 77-year-old Canadian retired investor, super type A gentleman. I ski with him, and we were skiing, and he's really complaining he has poor contrast, and his cataract in his only good eye is ready to be done, essentially. So he had a pretty complex history in his right eye. He has a history of retinal detachment repair and had undergone prior cataract surgery, and then had a BRVO, of course, while skiing in his left eye that I'm going to be doing cataract surgery on. And he's really feeling that he's getting a lot of glare, poor contrast, really having trouble on the ski slopes. So on exam, his vision's not horrible in the eye that we're going to be doing cataract surgery on. It's about 20/30 minus. And so, you know, we go through this whole long options of lens choices. You know, that's become quite time consuming over the last several years. But basically, he doesn't even want to learn about all these lenses because we're good friends. He just wants me to pick the lens, and he's sure I'm going to pick the right lens. And he just says, by the way, I will not tolerate glare and halos. I will not wear reading glasses because he's never going to wear any glasses whatsoever. So post-op day 1, he was 20/20 at distance and J2. Now, I had always noticed that Michael had very small pupils, much smaller than the average patient. You know, I assumed that that was giving him a bit extra depth of focus here. Post-op week 1, he never showed up to see me again. And so I had to call him and do a virtual visit. And he said, well, the eye's great. I don't wear glasses for anything. I'm feeling great. So I think that the RayOne EMV is an amazing lens. It really has no compromise with quality of vision. You achieve the very highest quality of vision. Again, effective lens position really cannot be emphasized enough because this lens stays perfectly centered. I mean, it's really super amazing. Those haptics really keep it centered. And using that bit of positive spherical aberration to give increased range without compromising vision like we see with some other lens types is really key. And even these small degrees of myopic offset for the non-dominant eye really increases the range, really 3 times more than you would expect with a standard monofocal lens without inducing any dysphotopsias.